The idea was to sensitize that never ignore anything yellow in the sclera or the skin of the patient. If the patient complains of high concentrated colored urine, please do look for jaundice, and then you can break it down to either pre-hepatic cause, hepatic cause, or a post-hepatic cause. So for intrahepatic cholestasis, PBC, alcoholic hepatitis, non-alcoholic steatohepatitis, viral hepatitis, drugs, herbs and toxins, pregnancy and hereditary conditions are usually the culprits. Now, having ascites is a serious issue because it tells you there is synthetic dysfunction and the patient is probably having less albumin production from the liver, and this should be taken with all seriousness and treated aggressively. Always keep in mind that as your liver keeps getting damaged of a patient, as a patient progresses towards chronic liver disease, paradoxically, the SGPT and SGOT might start falling.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Today, I would like to start with a caveat that this presentation is pretty much just to kickstart the discussion we must have with the audience, and I would be more than happy to take any queries, any real life case situations which you would like to discuss. Uh, Knowingly, I have not kept any particular case to be discussed because that would limit the discussion to that particular problem. So I will just go around with the sort of a how do you do it uh, approach to jaundice in our day-to-day practice. This is not going to be very, very complicated or very, how should I say, esoteric, in the sense we are not going to be discussing very rare things, but we'll be discussing more or less the very common sort of things which we see in day-to-day practice. And I request, rather I implore the audience to kindly ask questions so that with discussion we can clear more points than can come through with a didactic session. With that particular intro, I would like to start with this particular talk, which is approach to jaundice, day-to-day hepatology. And like I said, I hope we can have a very, very stimulating discussion, which will be mutually rewarding. So, as we all know, jaundice is something we all deal with on a day in, day out basis. And it refers to the yellowish discoloration of the sclera and skin that is due to hyperbilirubinemia, which occurs at a bilirubin level which is roughly greater than 50 micromoles per liter, which is usually what we see in clinical practice is not necessarily at this level. Many times you will see it even with 1.5 and 2 milligrams per liter, which would be 15 to 20 micromillimoles per liter. Now, deposition of bilirubin happens only when there is an excess of bilirubin, and this indicates two things. Either it can be increased production or it can be impaired excretion. I mean, there is no third reason why the bilirubin increases most of the times. Of course, you have conditions like storage diseases, congenital jaundices, hemolysis, and certain diseases like G6PD deficiency and all, which we'll be talking about later. So, suffice to say that when we talk about jaundice, we are discussing about yellowish discoloration of the sclera and the skin. Now, if you look at the epidemiology, the prevalence of jaundice will differ among different patient populations. The newborns and elderly more commonly present with the disease. Around 20% of born at term babies are found with jaundice, which is known as neonatal jaundice in the first week of life. This is most of the times self-limiting and is primarily due to immature hepatic conjugation process, and most of these children will do well. Occasionally, some of these children may have an excess of bilirubinemia, which can lead to crossing of the blood-brain barrier and lead to a very serious condition known as kernicterus. Hepatitis A, which is what we term as the normal sort of jaundice, Hep A and Hep E are two types of viral hepatitis which are usually water and foodborne. So these are what are known as fecal-oral transmitted things, and hepatitis A is found to be most prevalent amongst children. Most of the times, hepatitis A and E will tend to be self-limiting, but in 20% of pregnant females and in their last trimester of pregnancy, hepatitis E can even fulminate and lead to fatality, and it has significant morbidity and mortality associated with it. So please keep in mind that even though hepatitis A and E are considered the so-called easier variants of hepatitis, in very high levels of bilirubin, they can also lead to problems, specifically with Hep E, which can afflict the pregnant females in the last trimester of pregnancy and the very elderly and the very young. Now, bile duct stones, drug-induced liver disease, and malignant biliary obstruction usually occur in the elderly population. So why I'm talking about all this? Through epidemiology also, you can start segregating the causes of jaundice. We have an increased prevalence in India of alcoholic and non-alcoholic cirrhotics in males. Chronic Hep B is also found more in males, and malignancy of pancreas or sclerosing cholangitis is in our country primarily seen majorly in males. Now, if you look at bilirubin metabolism, which has been taken up by a lot of other speakers in the past, even on this platform, bilirubin metabolism is a complicated affair. I have tried to, in this busy slide, just try to simplify that when we talk about heme, which is the basic constituent of hemoglobin, when it undergoes oxygenation by heme oxygenase, it creates biliverdin. This biliverdin, when it gets reduced to biliverdin reductase, forms bilirubin, which then flows through the blood vessels. This bilirubin then gets bound to albumin, and this albumin is usually acted upon by the UDP glucuronidase transferase in the liver, which produces bilirubin glucuronide. Via the bilirubin tree, this bilirubin glucuronide goes into the colon, where the colonic bacteria decompose this and lead to urobilinogen formation, which basically passes out through urine, or some part of it passes through stool as in the form of stercobilinogen. Through all this, the portal vein serves a very, very important conduit between the liver and the colon through the portal vein enterohepatic circulation. So suffice to say that it is the breakdown of heme, which is a constituent of hemoglobin, which leads to biliverdin, which then gets broken down into bilirubin, which when bound with albumin through the liver is secreted into the biliary tree and transported to the colon through the portal vein enterohepatic circulation, and there gets converted into urobilinogen, which passes out through urine, or stercobilinogen, which passes out through stool. So if you look at the pathophysiology, I think this is something extremely important for each one of us to focus on. Unconjugated hyperbilirubinemia is most often caused by one or more of the following. It is either due to an increased production, it is either due to a decreased hepatic uptake, or it is due to decreased conjugation. This is exactly what is depicted pictorially on the right also, where the heme gets broken into biliverdin, gets changed into bilirubin, and then gets secreted out after glucuronic acid removal by bacteria as urobilinogen or stercobilinogen. Conjugated hyperbilirubinemia is most often caused by more than one of the following, which will be either dysfunction of hepatocytes, which is hepatocellular dysfunction, slowing of bile egress from the liver, that is to say that the bile does not excrete this efficiently from the liver, which leads to intrahepatic cholestasis, or it can be an obstructive pathology of extrahepatic bile flow, which is known as extrahepatic cholestasis. Now, please keep these pathophysiologies in mind. For unconjugated hyperbilirubinemia, either increased production, decreased uptake, or decreased conjugation. For conjugated, it can be hepatocellular dysfunction, where the hepatocytes themselves get damaged, or intrahepatic cholestasis, or extrahepatic cholestasis. When we say intrahepatic, we are talking inside the liver. When we say extrahepatic, we are talking about anything outside the liver. That can be pre-hepatic or post-hepatic. So the types of jaundice also, and of course, this is a very, very old sort of classification. Like I said in this particular talk, I think we should be discussing more rather than getting into too many semantics. The types of jaundice are either pre-hepatic, which can be due to excessive RBC breakdown, which overwhelms the liver's ability to conjugate bilirubin, or it is unconjugated bilirubin that remains in the bloodstream, which leads to jaundice. The hepatocellular jaundice, which is by far the most important type of jaundice, is due to dysfunction of the hepatic cells. The liver loses the ability to conjugate bilirubin. It gets overwhelmed because of dysfunction, and in cases where it may become cirrhotic, which means 50% of the integrity of the liver is lost, it compresses the intrahepatic portions of the biliary tree to cause a degree of obstruction even, and both conjugated and unconjugated bilirubin in the picture is termed as a mixed picture. They are found in the blood. For the post-hepatic, which is an obstructive pathology, there is an obstruction of biliary drainage, and the bilirubin that is not excreted will have been conjugated by the liver. Hence, the result here is one of conjugated hyperbilirubinemia. Now, why is this important? Because conjugated bilirubinemia is something where the conjugated part of bilirubin is secreted in the urine, and therefore you will have quite a good idea of what sort of jaundice you are dealing with simply by doing basic tests, looking at the urine, as I'll just show you. Of course, there are exceptions to this rule, but this will pretty much hold true for the majority of cases. Now, when we look at the potential causes for jaundice, there are multiple factors which lead to jaundice. When we talk about the pre-hepatic conditions, these can be hemolytic anemias, Gilbert syndrome, Crigler-Najjar syndrome, like these are congenital syndromes. Hemolytic anemia is very, very common. It can happen with certain drugs. It can happen due to hemolytic conditions. And then you have the hepatocellular jaundice, which can be due to alcoholic liver disease, viral hepatitis of all types, which can be A, B, C, D, E, and these days even F. Iatrogenic, which is due to medication like say AKT and amiodarone, and there are so many other medicines which can lead to iatrogenic jaundice. Hereditary hemochromatosis, autoimmune hepatitis, PBC, which is primary biliary cirrhosis or primary sclerosing cholangitis, and finally hepatocellular carcinoma. All these will lead to damage to the hepatocytes and cause hepatocellular jaundice. The post-hepatic, which is usually the obstructive pathology, is due to intraluminal causes such as gallstones. It can be due to mural causes like cholangiocarcinoma, strictures of the CBD or drug-induced cholestasis, and extramural causes which are outside the hepatobiliary tree, such as pancreatic cancer or abdominal masses like lymphomas, which can cause compression on the CBD and then lead to post-hepatic jaundice, which we routinely term as obstructive or extrahepatic jaundice. So, like I was saying, bilirubinuria can give you a good estimation of which type of jaundice is present prior to any further investigation, and this can be easily observed from the color of the urine. Now, as the conjugated bilirubin can be excreted via the urine because it is water soluble, unconjugated bilirubin cannot be. Therefore, dark, which is known as the Coca-Cola urine, this manifests in conjugated or mixed hyperbilirubinemias, whereas normal urine, if you see in a patient with jaundice, it will be due to unconjugated disease because the unconjugated part of the bilirubin cannot be secreted in the urine. Moreover, those with an obstructive picture will likely note pale stools or whitish stools due to the reduced levels of stercobilinogen and stercobilin entering the GI tract, which normally gives the color to the stool, which is yellow. As you would have noticed, most of my slides have this yellow background. The idea was to sensitize that never ignore anything yellow in the sclera or the skin of the patient. If the patient complains of high concentrated colored urine, please do look for jaundice, and then you can break it down to either pre-hepatic cause, hepatic cause, or a post-hepatic cause. You can also break it down to whether it is conjugated bilirubinemia or it is unconjugated bilirubinemia, and that gives you a clinical clue as to what you should be looking for, because you can't be investigating every patient with all the investigations possible for jaundice. Now, the causes of unconjugated hyperbilirubinemia are many. They can be either due to increased bilirubin production, impaired hepatic bilirubin uptake, or impaired bilirubin conjugation. Now, when we talk about increased bilirubin production, it can be due to RBC cell membrane disorders, which can lead to hemolysis like hereditary spherocytosis. Then you can have RBC enzyme disorders like G6PD deficiency. You can have hemoglobinopathies like sickle cell anemia, and you can have autoimmune hemolytic anemias. Suffice to say, the bilirubin is increased because there is hemolysis which is happening and the RBCs tend to break down. There is sludging in the spleen. So these patients may have splenomegaly, and these patients are usually producing more bilirubin because of breakdown of the blood cells. Then you have the impaired hepatic bilirubin uptake, which will happen in cases with hepatic failure, patients who have portal systemic shunting, and patients who are on medications like rifampicin, probenecid, and those who have congestive cardiac failure leading to congestive hepatopathy, and this causes impaired bilirubin uptake. Now there is the condition of impaired bilirubin conjugation, which happens with congenital conditions like Gilbert syndrome, Crigler-Najjar syndrome, neonatal jaundice, and in cases of advanced cirrhosis, hypothyroidism, and patients who are on medications like OCPs, which contain ethinyl estradiol, which impairs the bilirubin conjugation and leads to a condition of cholestasis and therefore causes hyperbilirubinemia. Now, coming to the causes of conjugated hyperbilirubinemias, you have intrahepatic cholestasis, which I said is what happens when you have congestion within the liver cells. You have hepatocellular injury, where there is direct injury to the hepatocytes. And then you have extrahepatic cholestasis, which is usually either due to obstructive pathology, or it can be due to neoplasia or some sort of stricture formation. So for intrahepatic cholestasis, PBC, alcoholic hepatitis, non-alcoholic steatohepatitis, viral hepatitis, drugs, herbs and toxins, pregnancy and hereditary conditions are usually the culprits. For hepatocellular injury, our most common conditions are viral hepatitis and alcoholic liver disease leading to alcoholic hepatitis. Then you have non-alcoholic steatohepatitis, which is the fatty liver, autoimmune liver disease. You have the drugs, which can be due to idiosyncratic drug reactions, neoplasias, that is HCC, infiltrative diseases like lymphomas and sarcoidosis, vascular conditions like Budd-Chiari syndrome, severe heart failure, which leads to congestive failure, and metabolic and hereditary conditions leading to hepatocellular injury. Lastly, you have the extrahepatic cholestasis, which can be due to choledocholithiasis, which is gallstone disease, where the gallstones migrate into the CBD and cause CBD stone with obstruction. You have neoplasias, which can be due to pancreatic cancers and cholangiocarcinoma, PSC, acute or chronic pancreatitis, and benign strictures. Now, suffice to say that it is not always possible to come to these conclusions, but 80% of the times, through a proper clinical history and very minimal investigation, we can come to a conclusion as to whether the patient has a hepatic injury, an extrahepatic injury, an intrahepatic injury leading to cholestasis, or a pre-hepatic injury. Similarly, with this sort of a roadmap, you can decide whether it is unconjugated hyperbilirubinemia you are dealing with or conjugated hyperbilirubinemia, and you can also have a fair idea about the etiology of what condition you are tackling. Now, coming to the physical examination, which is very, very important in any part of medicine, more so in cases of jaundice. These are certain features which are definitely commonly seen with jaundice: finger clubbing, scratch marks, leukonachia, spider nevi, palmar erythema, gynecomastia, Dupuytren's contracture, caput medusae, bruising, hepatomegaly. In many patients, you may have visceromegaly also in the form of splenomegaly. These are usually patients with portal hypertension. Some of these patients may develop altered sensorium, a altered sleep pattern. They might have irrational and exuberant behavior at times. These are patients with hepatic encephalopathy, and many times early hepatic encephalopathy will only manifest with a change in the sleeping pattern. So please do keep asking your patients with jaundice about this particular condition. And finally, there are the patients who you might detect for the first time in the first examination as having ascites. Now, having ascites is a serious issue because it tells you there is synthetic dysfunction and the patient is probably having less albumin production from the livers, and this should be taken with all seriousness and treated aggressively. So these are patients who are liable to go into hepatic failure. Now, having given you these basic roadmaps, I'll just come to the investigations, which I'm sure all of you distinguished clinicians are well aware of this. However, for the sake of completion of the talk, the LFT serum markers are definitely very, very important. I would love to have a discussion from the audience on how you go about doing this. But usually the blood markers which we use are bilirubin, which quantifies the degree of jaundice, albumin, which is a marker of the liver synthetic function. So albumin, I think serum proteins with a total albumin and globulin ratio is very, very important, because in my mind, I think that is one of the best prognostic, cheapest modalities you can use. The moment you have a patient who has a ratio of albumin globulin which is equal, or the globulin is more than albumin. You are dealing with chronic liver disease. You are looking at a patient who has subacute hepatic failure and is a likely candidate to progress to cirrhosis very fast. So this is definitely a very, very important marker which criminally gets underused. It's a simple test. It's available pretty much in most of the labs, even in the smallest centers. AST and ALT, that is SGOT and SGPT, are liver enzymes, as we are aware. They are markers of hepatocellular injury. Always keep in mind that high AST and ALT does not always correlate with the degree of severity of the disease. Always keep in mind that as your liver keeps getting damaged of a patient, as a patient progresses towards chronic liver disease, paradoxically the SGPT and SGOT might start falling. This is not a good sign because this tells you there is less of viable hepatic parenchyma left for the liver enzymes to rise. This is actually a bad sign, and prognostically, it tells you that the patient has become a candidate to be on a transplant program. Alkaline phosphatase is raised in biliary obstruction as well as bone disease. It also increases in a physiological condition like pregnancy and in certain malignancies. So, just having a high alkaline phosphatase always does not mean that it is due to a liver condition or due to biliary obstruction. Gamma GT, which is something which we don't ask for routinely, is more specific for biliary obstruction than alkaline phosphatase. Because I practice in Gujarat, which is technically a dry state, where many people who are consuming alcohol come to us and tell us that they are not consuming alcohol. Gamma GT is also a good marker to find out. If you have a gamma GT which is 4 to 5 times more than normal and you do not have any signs of obstruction, you can bet your last rupee that this is a person who's consuming alcohol. So we use it as a surrogate marker of finding out if a patient is drinking, and do not always believe what the patient says, because 50% of my patients in clinical practice deny taking alcohol, and it is when we find this test and then confront them that they accept that they are consuming alcohol. So this is something unique to my part of the country, but I'm sure this is not unique to the rest of the country also, because most patients want to hide this sort of a history, but one has to be vigilant about it. Now, coming to the AST, ALT, and ALP levels, there have been multiple talks in our hepatology bodies where we have discussed these tests for a full day or maybe a day and a half. And these excite a lot of hepatologists and a lot of discussion takes place. However, I think we need to keep things in perspective. An AST ALT ratio more than 2 to 1 is seen usually in alcoholic liver disease. However, I am not asking this distinguished elite panel of clinicians to only rely on this to decide whether it is ALD or not. However, this is more commonly seen. If the SGOT-PT values are in thousands, then the hepatocellular disease is likely due to toxins like acetaminophen, or they might be due to ischemic hepatitis, or it could be viral in etiology, which could be either Hep A, B, C, D, E, F, or G. If alkaline phosphatase levels are 5 times elevated than normal, liver transaminases are normal or less than 2 times normal, most likely cause is biliary obstruction. High serum ALP levels can be due to a biliary injury and can be differentiated from bone disorders by ordering a gamma GT profile. An increased gamma GT will confirm hepatic origin. So please keep this in mind. This is something quite specific. Gamma GT will help you in distinguishing this. If AST, ALT, and ALP levels are normal, then the jaundice is not due to liver or bile duct injury. Then you have to look at other causes, which could be hemolysis, or it could be some sort of storage disease, or it could be even due to some sort of drug-induced problem or traditional medicine like Ayurveda and all. The cause must most probably be pre-hepatic, inherited disorders of liver conjugation or blood disorders, or defect in hepatic excretion, where you have all these things as normal, the AST, ALT, and ALP levels. And this is usually seen in conditions like Rotor syndrome and Dubin-Johnson syndrome, which are congenital conditions. So, to summarize, the laboratory analysis is important. The pre-hepatic jaundice will show increased unconjugated bilirubin, no significant changes in conjugated bilirubin, AST, ALT, ALP, gamma GT, albumin, or prothrombin time. The LDH will be raised and the haptoglobins will be low in pre-hepatic jaundice. In intrahepatic jaundice, the unconjugated bilirubin rises mildly, conjugated goes up significantly, AST and ALT also increase, the gamma GT increases, the albumin goes down, there is prolongation in the PT, that is the prothrombin time, and the haptoglobins are decreased. For post-hepatic jaundice, both the unconjugated and the conjugated part rises, with more rise in conjugated bilirubin. AST, ALT, ALP, gamma GT all increase. Prothrombin time prolongs in obstruction, but it responds to vitamin K very well, and LDH is also raised. So please keep in mind that albumin tends to go down in intrahepatic jaundice only. It doesn't go down in pre-hepatic jaundice or post-hepatic jaundice, except when there is nutritional compromise of a long-term duration. In an acute phase, this should tell you that you are dealing with intrahepatic jaundice, and that is why I am uh, I believe very strongly in looking for an albumin at the very outset in my patients who present to me with jaundice. Now I come to the part which is beyond the blood, because we can keep discussing blood investigations and there are multiple things. I haven't even talked to you about the viral markers. I'm assuming most of us know that. We talk about the imaging of the liver and biliary tree. So ultrasound is an indispensable aid in smaller and even bigger centers, because it is the initial imaging modality of choice in suspected cholestatic jaundice. It is non-invasive, inexpensive, and like I said, widely available. It also has a sensitivity of 55 to 91% for detecting dilated bile ducts and biliary obstruction. And once you detect dilated bile ducts or biliary obstruction, then comes the role of other things like ERCP and EUS and other things which I'll discuss. It can also detect gallstones and periampullary masses and provide information on the hepatic ecostructure and features of portal hypertension. So suffice to say that imaging of the liver and biliary tree gives you a whole lot of information for very little cost, is easily available. Now you could say that if it has a sensitivity of 55 to 91%, why is that? That also depends on inter-observer variation. And if you have a good sonologist, I work with some excellent sonologists, and I have so much faith in their reporting that I have gone ahead and done ERCPs based simply on a sonography report, because once my sonologist tells me that he can see stones. And please keep in mind, for gallstones and also for CBD stones, a sonography is superior to a CT scan. Most of us tend to think that the CT scan, because it is a more expensive modality, is a better modality all around. Not so for gallstones. For gallstones and CBD stones, my go-to sort of uh, investigation is a sonography. And if I have some doubts which are not cleared by sonography, I would ask for an MRCP rather than asking for a CT scan, where translucent stones are usually missed. So please keep this in mind, that just getting a normal CT scan report does not rule out the presence of gallstones or of CBD stones. So this is the sort of picture you see with the ultrasound screening. On your left is the intrahepatic jaundice, where there is coarsening of the ecotexture within the liver. Then you have the obstructive jaundice, where there is dilatation of the intrahepatic biliary radicals. And you also have the extrahepatic jaundice, where you see congestive hepatopathy of the liver. The liver is quite grossly enlarged. And you also have dilatation of the biliary tree. Then comes MRCP, which is performed when biliary dilatation or its cause remains unclear. It is again a non-invasive technique which provides high-resolution imaging without contrast. That also becomes important, because many of these patients will have hepatorenal disease, and you cannot use contrast, and therefore CT scan gets precluded. So an MRCP would be a safer and a better choice. And in this particular slide, you can see obstruction as shown by the arrows of the main hepatic duct junction with dilatation of the intrahepatic biliary duct. CT scan, I am not trying to knock CT scan. It can reliably detect ductal dilatation and is superior to ultrasonography for certain things. However, CT involves exposure to radiation and nephrotoxic contrast agents, and only 10% of the gallstones are visualized on CT. However, it is superior if you are looking for hepatocellular carcinoma or some sort of solid tumor or lymphomas or compression on the biliary tract from extraluminal organs. There, a CT scan is definitely superior. However, please keep in mind, for bile duct stones and for gallstones, a sonography or an MRCP is your go-to resource rather than a CT scan. So I come to the other imaging of the liver and biliary tree. These are two modalities which are not available widely, but in advanced GI centers like mine, we use these quite frequently. We have what is known as the EUS, which is endoscopic ultrasonography, which is an invasive technique in which an endoscope with an ultrasound probe is lowered into the duodenum during gastroscopy. This provides detailed information about the biliary tree and pancreas. The beauty of EUS is you can also do therapeutic intervention. It allows for biopsies and fine needle aspiration, and it is particularly useful for staging periampullary and pancreatic malignancies. Intraductal ultrasound is a new modality. It is known as IDUS. This is a newer imaging modality which involves cannulation of the common bile duct or the main pancreatic duct with a mini probe through the scope to visualize the biliary and pancreatic duct. It is like what we term as a mother baby scope, where the mother scope is a large scope, and through the suction channel of the mother scope, a baby scope is put through into these ducts, and one can do an intraductal ultrasound. Now, the passage of the probe can be difficult in tortuous or strictured ducts, but IDUS is more accurate than ERCP for detecting small stones in dilated ducts and determining the nature of the bile duct strictures. So, this is again something which is coming up slowly in a big way in the West, and it is being taken up in India also in many centers. Then I come to liver biopsy, which is again a very, very important tool in the armory of a hepatologist. If patients have jaundice and deranged liver blood results with a normal liver etiology screen and imaging, a liver biopsy should be and can be considered. These days, we do not do liver biopsy for fatty liver because we use something known as a fibroscan, which is a non-invasive condition. But a liver biopsy is mandatory in cases of autoimmune liver disease and certain biliary tract disorders like small duct, PSC. There are adverse effects, including pain in 20% of the patients and severe complications which happen in less than 0.6% of the patients, which can include hemoperitoneum, puncture of other organs, pneumothorax, and biliary peritonitis. Last thing which one needs to keep in mind is there can be sampling errors which can happen with liver biopsy. So any good liver biopsy should have at least 4 portal triads so that the histopathologist is able to tell the hepatologist what the condition is. In patients with deranged coagulopathies, patients with deranged bleeding profiles like in cirrhotics, we do what is something known as a transjugular liver biopsy, where we go through the transjugular vein, and that is a very, very skilled procedure. It is done by interventional radiologists and by interventional hepatologists, but that is a much safer way to do a liver biopsy than to do a percutaneous biopsy, which is what is usually done in most of the cases. The reasons to do a transjugular liver biopsy are few and far between. We do it before a liver transplant in cases where there is a dilemma of diagnosis and a percutaneous biopsy is precluded. So it is a very small percentage of patients, but it is a modality which you must be aware of, because that is something which can be offered to the patient, and many times it is critical in the approach to your investigation and coming to a conclusion. So I would like to summarize my stepwise approach to the investigation of jaundice. Like I've said, I haven't probably told you anything so far which you didn't know, but I think we should discuss how we go about this in day-to-day clinical practice, because that way we will have a more robust way of arriving at a diagnosis and not missing out on things. A good history will never be supplanted as a major tool in medicine. So please take a proper history. And in this, I would like to tell the audience 3 things are very important. Please ask the patient if they are taking any sort of dietary supplements. These days, a lot of these patients go to gyms, they are given all sorts of supplements, and many of them are hepatotoxic. So please take a history of any dietary supplements the patient is taking. The second thing is, patients usually will not volunteer any information on any sort of traditional medicine like Ayurvedic, Unani, Siddh, and traditional Chinese medicine, herbal medicine, and all. Many of these medications are very, very hepatotoxic. Many Ayurvedic drugs contain heavy metals, and many of these drugs have even led to hepatic failure. So this is not a criticism of Ayurveda. This is just the way it is. You need to find out if the patient is taking this, and this is definitely a very, very key point in history which is missed very frequently, and one needs to take it. And lastly, you must ask the patient if they have been taking any new drug recently. Many times this is an idiosyncratic reaction to certain drugs. So please take a drug history. It is very important. Traditional medicine drug history, and any dietary supplements being taken by the patient should constitute a definite question, which has to be a leading question from your side to be asked to the patient. Then comes the physical examination, which we have discussed in my few previous slides, the urine analysis and the blood test, which I have discussed. If you find increased conjugated bilirubin and an abnormal hepatocellular liver blood screen, look for the etiology of the liver, treat the underlying condition. If you do not find the liver etiology, look at further higher imaging or an optional situation for a liver biopsy here. And if you cannot find anything through imaging, then a liver biopsy becomes mandatory. If you have increased conjugated bilirubin and abnormal cholestatic liver blood screen, then look through a sonography for biliary dilatation. If there is biliary dilatation, do further imaging either in the form of MRCP and do an ERCP if there is gallbladder stones or ductal stones in the common bile duct. If the liver etiology and the screen is negative, then a biopsy again becomes mandatory in this condition. Now, coming to the right side of this slide, if you have increased unconjugated bilirubin, otherwise normal liver blood screen in terms of ALT, AST, and ALP, look for hemolytic screen, work up these patients for sickle cell anemia, look for a history of falciparum malaria, look for conditions like tropical malarial syndrome, also look for conditions like G6PD deficiency. So work up for hemolytic anemia, and also keep in mind the condition of Gilbert syndrome. Now, many of these patients will come to you, they are very concerned, they are going out abroad and their blood screen has come like this, so they are worried. You have to tell them that this is a benign condition and Gilbert syndrome is something which doesn't progress. It is a self-limiting condition and the patient will never have normal bilirubin, but usually the bilirubin will be below 2.5, 3 milligram per cent. So reassure these patients, tell them not to go for very long times without food. Fasting increases the bilirubin in patients with Gilbert syndrome, and they shouldn't go out in the sunlight for too long a period of time, because that again increases the breakdown and the hemolysis in patients with Gilbert syndrome. So Gilbert syndrome is something where the patient needs to be reassured. Now, coming to the treatment, and I will not talk about things like IV fluids and glucose and pantoprazole and ondansetron and metoclopramide for vomiting and all. We can discuss that if you want, but I think the treatment is very dependent on the cause, and most of the times it is symptomatic. So if you have liver dysfunction, the treatment of liver disease obviously affects the bilirubin levels. So in cases like alcoholic hepatitis, the treatment is firstly directed towards stoppage of alcohol usage. Same is the situation for drug-induced hepatitis, where the treatment firstly has to focus on withdrawal of the suspected drug. For viral hepatitis, nowadays antivirals are the method of choice once the patient has gone beyond the stage of acute viral hepatitis. As far as viral hepatitis antivirals are concerned, they are usually used for chronic hepatitis B and chronic hepatitis C. As far as Hep A and E are concerned, there is no need to give antivirals. These are patients who just need symptomatic treatment and may require IV fluids and supplementation if they are vomiting. Otherwise, most of these patients can do well at home and they can do with the minimal sort of restriction to their lifestyle. In primary biliary cholangitis, the treatment of choice is ursodeoxycholic acid, because it helps in reducing the cholestasis and also helps in stabilizing the hepatocytes. Patients with end-stage liver disease, liver transplantation is the only method of choice as a treatment modality. Now, this might sound very brief and very insufficient, but what I'm trying to focus on is that you have to find the cause, and once you have the cause, the treatment becomes easy. As a general rule, in jaundice, we try to supplement glucose if the patient is not diabetic, just to maintain calories. If the patient is dehydrated, we give them IV fluids. If the patient is vomiting a lot, you would definitely want to give them antiemetics. If there is condition of obstruction and extrahepatic cholestasis, the patient has a significant pruritus, you can use steroids occasionally with caution for a limited period of time. My personal choice is to use UDCA, phenoxypidine, and also in certain cases we use cetirizine. But all these things have to be monitored. These are not things the patient should be using unmonitored, because that can lead to its own set of issues. So in patients with obstructive jaundice, we also have to relieve the obstruction. So endoscopic procedures and occasionally surgery remain the backbone of the therapy. ERCP, EUS, clearance of the CBD with a stent. So the goal is to remove or relieve the obstruction, and ERCP is one of the preferred methods. We use sphincterotomy, balloon dilatation, and stent placement. And one of the life-threatening complications with ERCP of this method is pancreatitis. So in cases of malignant obstruction, surgery would remain the method of choice. If surgery is not possible, as a matter of palliation, I would like to put in a metal stent into the CBD so that the patient has drainage of the bile and is relieved of the pruritus and cholangitis. This obviously does not stop the malignancy from progressing. This is just for palliation and improving quality of life. These are patients who are also deficient in vitamins, which are the fat soluble vitamins, and they need to be supplemented. And these patients have to be taken care of nutritionally either through TPN or through IV fluids. Thank you so much. And it would now be my pleasure to take any questions, and I hope we can have a very, very stimulating discussion. Over to you, Laksh.
Thank you so much, sir, for such an insightful session. And now we'll be discussing upon the questions that have come. Dr. Ashok has asked, in cases of portal hypertension and gallstone, what is the scenario?
What is the
scenario seen in portal hypertension and gallstone cases?
So if I can hear you, your voice is getting dropped. I think you are asking me what is the scenario in portal hypertension and gallstone.
Yes, sir. Yes, sir.
Okay.
Yes.
So let me take the gallstones first. I think once, Dr. Ashok, you have gallstones, the one thing which one can't get out of is a laparoscopic cholecystectomy. So the first thing is to do an imaging in these patients. If the gallstones are restricted only to the gallbladder, you need to refer to the surgeon for a laparoscopic cholecystectomy as soon as possible. Now, the problem with gallstones is that only 20% of the gallstones will become symptomatic in the course of the life of the patient. 80% of these patients may never have an episode of cholecystitis or the conditions like obstructive jaundice. However, we do not know which patient will develop this complication and who will not. So, as a safe modality, once you have gallstones, subject the patient to laparoscopic cholecystectomy if the stones are restricted only to the gallbladder. However, if you have the gallstone which has migrated into the CBD, what is known as choledocholithiasis. Having gallstones in the gallbladder is cholelithiasis. Having gallstones in the common bile duct is choledocholithiasis. That is a serious condition because these gallstones can get into the pancreatic duct and they can lead to a potentially life-threatening serious condition known as pancreatitis. So these patients need an ERCP, which is an endoscopic retrograde cholangiopancreatography, which is done by interventional gastroenterologists, therapeutic endoscopists, who will then do a sphincterotomy in the second part of the duodenum, open the ampulla of Vater, and then through a basket, Dormia basket or a balloon, extract the stone, and if required, place a stent, which can be removed after 4 to 6 weeks, and ensure that the drainage takes place. So if you have, let me put it to you this way, you have two patients. One patient has gallstones, no CBD stones, has no other symptoms. Send this patient to your surgeon for a laparoscopic cholecystectomy. The gallbladder gets removed, and that's the end of the story. Now you have another patient who has gallstones and CBD stones. You send him to your gastroenterologist first, who does an ERCP, removes the stone, and then after 2 weeks, the patient can undergo a lap chole and get the gallbladder removed. So that will take care of these two different subsets of patients. Now coming to portal hypertension, which you mentioned, portal hypertension is also of two types. You have portal hypertension, which can be extrahepatic in origin, and you can have portal hypertension, which is of intrahepatic origin. So now you have portal hypertension of, say, a pre-hepatic or hepatic condition like, say, cirrhosis or Budd-Chiari. The scenario for Budd-Chiari syndrome is that these days we ask our interventional radiologist to stent because these are suprahepatic veins which are obstructed and these are veno-occlusive diseases. So putting in a stent restores the blood flow and the portal hypertension gets decompressed. When you talk about cirrhosis, chronic liver disease, that is a different type of portal hypertension because here you have fibrosis of the liver tissue which is causing compression of the portal system, and due to that, to decongest, there is a lot of collateral formation and splenomegaly. These are the patients who present to you with GI bleed. They come to you with hematemesis, melena, and that is a potentially life-threatening situation which I had discussed in my previous talk on upper GI bleed, for which we usually do endoscopic banding and sclerotherapy, and occasionally we even inject cyanoacrylate glue for gastric varices. So portal hypertension, the primary treatment for portal hypertension is to start them on non-selective beta blockers like propranolol. Please take a history of COPD. If your patient has chronic obstructive pulmonary disease or asthma, it is not safe to give beta blockers. In those cases, one can use nitrates, but the nitrates are not as useful as beta blockers for the prophylaxis of portal hypertension. And please keep in mind that apart from the endoscopic treatment for portal hypertension like banding and sclerotherapy and glue, the only thing which is prescribed for secondary prophylaxis and primary prophylaxis of portal hypertension, it is beta blockers like propranolol and all. So you have to give this to these patients to reduce the portal hypertension, because portal hypertension will inevitably lead to GI bleed, which can be fatal.
Thank you so much, sir, for that complete and basic and accurate explanation. I think Dr. Ashok will have no queries remaining. And the next question is by Dr. Mani about any latest treatment modality for hepatitis B chronic carrier state.
Okay, that's a very good question, and thank you for that question, doctor. I think the good news as far as hepatitis goes is that what we are finding is that there are newer and newer drugs which are coming in. If you look at the old drugs like lamivudine, telbivudine, uh, we have been using these for any number of years. The newest modality which has come is in our country is tenofovir alafenamide, which is known as TAF. This tenofovir alafenamide is a safer version of tenofovir which we were using earlier. We were also using entecavir, which was available to us, and telbivudine and lamivudine we don't use very often these days. And the use of pegylated interferon has been given up in cases of hepatitis B because it was found to be quite toxic for the patients, and now we have better drugs. So, a short answer to your question is that now we have TAF, which is the newest modality, and that is what we use. Amcitrabine is another drug which is not available in our country freely, which is available in the West, which is also used for chronic hepatitis B, the carrier status. Now, since you asked about the carrier status, let me just define it for the audience. If your patient of hepatitis B has acute viral hepatitis which you diagnose today and you start treating the patient becomes well, but you must always call this patient back at 6 months and test for HBsAg, which is the surface antigen. If the patient is positive for HBsAg at the end of 6 months, this is considered a chronic hepatitis carrier. Now, when we say carrier, the usual denomination earlier used to be a healthy carrier and what was known as a unhealthy carrier. Now that denomination has been given up, but effectively what it means is the virus active or is the virus inactive? So at 6 months, the patient may be HBsAg positive, which means that the virus has integrated into the hepatocytes. However, if the virus is not multiplying, you do not treat this patient. And how will you decide that? You test through a test known as HBV DNA quantitative, which is basically a PCR test which detects what is the number of actively multiplying Hep B virions in one drop of blood. If it is significantly raised, these are the patients who need to be on therapy. Now, the next question, usually a frequently asked question, so I'm just answering it, is how long do we continue this treatment? The usual recommendation is to give the antiviral for a minimum of 1 year, then retest the HBV DNA quantitative. If it is suppressed, the patient can be stopped from medication. Otherwise, for many patients, specifically Hep B cirrhotics, patients who have HCC, these drugs have to be taken lifelong.
Thank you, sir. Dr. Ashok has asked, in cases of annular pancreas, if a patient comes with jaundice, how to approach such case?
It's no different, Dr. Ashok, how to approach these patients. In a patient with annular pancreas also, the basic fundamentals of treatment remain the same. The only thing about annular pancreas is these are patients who are susceptible to recurrent attacks of uh, acute on chronic pancreatitis, and many of these patients may have chronic pancreatitis due to repeated attacks of acute pancreatitis over a period of many years or months. So your treatment for jaundice would remain the same, but you would also need to rule out any pancreatic malignancy, because pancreatic malignancy is more commonly seen with annular pancreas, And annular pancreas, ventral pancreas, pancreas divisum, these are all what we term as paranormal presentations of the pancreas leading to conditions like pancreatitis. So look for any obstruction, because many times annular pancreas, if it is very large, can cause compression of the second part of the duodenum, and that can actually lead to obstructive jaundice. So if it is not obstructive jaundice, viral hepatitis, your treatment modality remains the same. If it is obstructive jaundice, you would definitely need to stent and consider even resection of the annular pancreas if it is very tightly encasing the second part of the duodenum.
Thank you so much, sir. Dr. Ravindra has asked, what is the role of barbiturates in neonatal jaundice?
Barbiturates have a limited role, Dr. Abe, in the treatment of neonatal jaundice. Neonatal jaundice, as we all recognize now, is a self-limiting condition. Most of the times, these patients are only given phototherapy, and that suffices. Barbiturates are used with caution in these patients, and mainly in those patients who are having convulsive disorders. So it is very, very seldom that we use them these days, because now you have better modalities available. And barbiturates have a very limited role now in the management of neonatal jaundice.
Thank you, sir. Dr. Ravindra has also asked why jaundice is also known as icterus.
Sorry, why jaundice?
Is also known as icterus.
Icterus is basically derived from a Greek term which basically means yellow eyes. It is jaundice is the technical term for your sclera and the skin getting yellow. Icterus is basically the sort of color. Icterus in Greek actually means yellow color. So that is why, because jaundice is associated with the yellow color. That's why.
Thank you, sir. Dr. Konduri has asked, can there be raised alkaline phosphatase in a case of chronic alcoholic disease?
Yes, that's a very good question. Yeah, thank you for that question, doctor. I think you've raised a very good point. Yes, you can have increased alkaline phosphatase even in a case of alcoholic hepatitis, because even though alcoholic hepatitis is a hepatocellular injury due to alcohol, but many of these patients also have a cholestatic element. Alcohol also causes cholestatic disease of the liver. So you can have increased alkaline phosphatase even with alcoholic hepatitis, though it will not be as high as you see in obstructive pathologies like choledocholithiasis, strictures, or pancreatic malignancy. But yes, that is a very good question you have raised. It is definitely not an exclusionary thing. It can be seen in patients with ALD also.
Thank you, sir. Dr. Shivani has asked, what level of alkaline phosphatase can be considered as significant?
Usually, depending on your lab's values, anything which is more than 2.5 times normal has to be considered significant. Many times, even a marginal increase in patients with significant pruritus is to be taken as significant. So it is also a factor of the clinical picture. Many of these patients who have cholestatic, benign cholestatic, recurrent cholestatic disease of liver will present to you only with pruritus. Most of my references for these patients come to me from my dermatology colleagues, because patients first go to a skin specialist for itching, and it is there
Yeah.
that they're expected to have some sort of cholestatic jaundice and then get referred to us. So anything which is 1.5 to 2 times more than your normal lab values, and lab values will differ because every lab uses a different set of reagents. Whether it is dry chemistry you are using or wet chemistry, it also matters on that. So I'm not giving you some lab figures, but anything which is up to 2 times normal is definitely significant.
Thank you, sir. Dr. Ashok has asked that does the food habit in different parts of India and the quality of water people consume have any bearing on the etiology of jaundice?
I think that's a very good observation, Doctor, and
Ashok.
definitely the quality, Doctor Ashok, right?
Yes.
Yeah.
Yes, sir.
So, yeah. So, Dr. Ashok, the quality of water is very, very important for fecal-oral viral hepatitis, which is A and E. I stay in the city of Ahmedabad, where we have certain areas where hepatitis E and A breaks out every monsoon, and the reason for that is that the pipelines for water and drainage are running parallel, and when they break, that sewage mixes with the drinking water, and we have epidemics in certain localized conditions. So, yes, water sanitation and the safety of the water supply to our citizenry is definitely important in the causation of viral hepatitis of the type of A and E. Obviously, hepatitis B and C are parenterally acquired, so we are not talking about those. Those are conditions which spread through IV drug use, blood products, sexual encounters, and also unsafe injection practices like not using disposables or using the same so-called disposable in multiple patients. The second thing about the diet part of it, I don't think in India it is much of an issue. But if you look at countries like Korea and in Taiwan and China, where they eat dog meat, and there are certain parts of India like Nagaland where dog meat is taken, communities which consume dog meat have a very high propensity to develop hepatitis B and C. That has been known to happen because these dogs are infected, and when they are slaughtered, the people who do that tend to get infected. And also, the rate of hepatocellular carcinoma is one of the highest in Korea and Taiwan, and it has been postulated that it is due to the dog meat. But in India, I think for the majority of people, it's not the diet which causes jaundice, it is the bad water which leads to the infective hepatitis A and E.
Thank you, sir, for that epidemiological insight. Dr. Rahul has asked what is the role of doing urine test for urobilinogen?
That sorry, could you repeat that?
So, what is the role of doing urine test for urobilinogen?
See, urobilinogen, we basically are looking to see whether it is conjugated bilirubinemia or non-conjugated. So if you have urobilinogen in the urine, this tells you that this is conjugated uh, hyperbilirubinemia, and like we discussed, it lets you know the etiology of the conditions you are likely to be encountering. So it is not something which you need to do always as a matter of routine, because if you are convinced that you know what is the etiology, this is not something which you need to do. But if you are in a dilemma whether it is conjugated or unconjugated, this is a cheap, easily available test to do to differentiate between conjugated and unconjugated hyperbilirubinemia.
Thank you, sir. Dr. Navneet has asked, does patient hemoglobin level can help us in distinguishing between pre-hepatic and the other types of jaundice?
I don't think hemoglobin has any role to play in distinguishing this. It is important to keep in mind that in patients with advanced liver disease, you will definitely have low hemoglobin, because these are patients who are anemic due to their portal hypertension, due to history of GI bleed, they have nutritional compromise, there is synthetic dysfunction with albumin. But per se for jaundice, just looking at the hemoglobin is not something which you can use as any sort of sensitive marker.
Thank you, sir. Dr. Mahadev Desai have asked to discuss the importance of delta bilirubin and in many laboratory reports.
Uh, Sir is a master on this. I don't think I can add much to what he discussed in his own talk. But yeah, the delta bilirubin again is something which we need to focus on in case you are having high bilirubin levels which are not responding to routine treatment. Delta bilirubin has to be looked for. Usually, the problem with delta bilirubin is that not many labs are doing it unless you ask for it specifically. Most of the time, the delta bilirubin report is not part of our normal investigative armamentarium. But yes, delta bilirubin is to be kept in mind whenever you have a patient who's improving clinically but is still showing very high levels of jaundice. It is usually due to the fact that the delta bilirubin is conjugated and adding to the bilirubin load. So that is the basic, utility of looking at the delta bilirubin.
Thank you, sir. Okay, we have next three questions related to certain drugs. Dr. Mani has asked whether UV leave is beneficial in cholelithiasis.
Whether UDLIV is beneficial for?
Cholelithiasis, gallstones.
Uh, See, Dr. UDCA is known to reduce cholestasis. So, theoretically, yes, it is supposed to be useful for gallstones. However, my clinical experience over the years has taught me that it probably is no better than a placebo when it comes to treatment of gallstones. I would use UDCA for certain specific indications. One is when you have pregnancy induced cholestasis. It is very, very useful in conditions like benign recurrent intrahepatic cholestasis of pregnancy. I also use them in cases of cholestatic liver disease to reduce the pruritus. However, when it comes to gallstones, I don't think UDCA plays much of a role, and it is no better than a placebo, and an expensive placebo at that. So I would rather desist using UDCA in cases of gallstones. If you have a patient with gallstones, the best thing is to do is to send him to the surgeon to get the gallbladder removed. I think that sorts your problem out rather than giving them any medication.
Thank you. Thank you so much, sir. Dr. Mansa has asked whether Hepamex syrup is useful in cases of jaundice.
Hepamer syrup, which is L-ornithine L-aspartase, is basically a sort of a supportive supplement in cases of hepatic uh, uh, encephalopathy, where patients have false neurotransmitters being generated at the blood-brain barrier. So you use things like dopamine agonist and supplements like L-ornithine L-aspartase. It helps, but it has no role in the management of acute hepatitis. Unfortunately, in our country, we see people being prescribed Lib 52, Hepamers, Udiliv, lots of vitamins, and all this stuff. They are completely only adding to the cost of therapy, and they are no better than any placebo. Also, there are a lot of uh, these so-called widely held beliefs that people should not eat anything which is yellow, people should not eat much, they should only be on liquids. If your patient
Mhm.
is not having severe anorexia, is not vomiting, it is best that they continue eating a normal diet so that they do not become nutritionally deficient. In conditions like hepatitis A and E, I would very seriously implore this audience, please do not starve your patient. Ask them to avoid a very fatty fried diet and ask them to avoid milk. I think that is more than enough. They can have roti, sabji, dal, bhat, all that is fine. So long as the patient has appetite, please do not starve them, because this is good. It maintains their nutritional levels, and all these supplements do more harm than good many a times. So there's no reason to use these things. But unfortunately, because the liver is a very forgiving organism, it's one of the most resilient organs in the body. People keep abusing it with all sorts of herbal medications and things like Lib 52, which is nothing but colored water. So end of the day, it's a choice you make for the patient. So please play the devil's advocate for your patient and do not prescribe these drugs.
Thank you so much, sir, for that important point. Dr. Mahima has asked whether tablet Heptal is beneficial or not.
Dr. Mahima, do you want a straight answer? No. Now let me tell you why it is not very useful. The problem with all these things is that most of them are not standalone medications. These are all what we term as co-prescriptions. And Heptral also basically works only by stabilizing the hepatocytes. Now that is not something for which you should be using such an expensive drug. Personally, I do not use it. And if you look at the evidence, it really doesn't help matters in any significant manner. Now, the problem with this class of drugs, and this is basically what is known as SAMI. So, this is as adenosyl methionine, which is used. This is not really found to be of any great use. Silymarin, SAMI, uh, LOLA, which is L-ornithine, L-aspartase, UDCA, all these drugs, along with essential phospholipids, have been tried in acute hepatitis with varying amounts of success. But if you look at the Cochrane review, which is the biggest meta-analysis in the world, it says that these things are no better than placebo. And I think that is pretty much the final word. So we should desist from using this.
Thank you so much, sir. So we have a lot of other questions. We'll try to touch over them as much possible. So Dr. Mahima has asked that in her practice, she sees patients with increased alkaline phosphatase only, and the SGOT, SGPT remains normal. So what are your views about these kind of patients?
So, like I said in my slides, if you have a patient with only increased alkaline phosphatase, look at cholestatic liver disease as one of your likely things. Now, if you talk about cholestatic liver disease, it can be either at the hepatocellular level or it can be extrahepatic, right? So, first you have to rule out some sort of obstruction, because this obviously is some sort of obstructive liver disease. Now, this could be either gallstones in the CBD obstructing the common bile duct, or it could be a stricture, or it could even be a malignancy. So, these are patients who will have an isolated rise in the alkaline phosphatase. If you are confused whether it is because of hepatobiliary tree or not, then please get a gamma GT done. If the gamma GT is high, it tells you that this is definitely of hepatic origin, and you should then either subject the patient to slightly higher amount of imaging in terms of an MRCP or a CT scan if you are expecting something outside the duct. If you are suspecting something inside the duct, an MRCP is superior. If your sonography has not given you the clue, like I discussed. And once you find the etiology, you will tailor your treatment accordingly. If you're dealing with a stricture, you dilate the stricture and you put in a stent. If it is a benign stricture, it gets resolved by stenting. If it's a malignant stricture, operable, you subject the patient to surgery. If inoperable, you put in a metal stent for palliation. If it is a compressive disease from outside, you take care of that. It can be due to tuberculosis, it can be due to lymphoma, it could be sarcoid. There are multiple things which can lead to these lymph nodes compressing. So you treat that particular condition. So it will all depend on what you're doing. And lastly, please take a drug history, because many of these drugs can also lead to isolated rise of ALP. There are very few drugs which will not cause a rise of the SGOT-PT. Usually the SGOT-PT rises in tandem with ALP. But there are a lot of drugs like rifampicin and all, where the alkaline phosphatase is what rises far more than the SGOT-PT, which may actually be low normal or just high normal. And these are the conditions you need to keep in mind and then treat it.
Thank you, sir. Dr. Saurav and Dr. Ruchi have a common question. How to evaluate a female patient who doesn't drink alcohol but has a liver parenchymal disease? What could be the etiology and how to evaluate?
A female patient who doesn't drink alcohol but has
Liver parenchymal disease.
liver parenchymal disease. Yeah, very good question. So you could be dealing with a patient who has either a fatty liver which has progressed to cirrhosis, or you could be dealing with a viral condition like Hep C or Hep B, which can lead to cirrhosis. Alcohol is one of the reasons for chronic liver disease. There are multiple other conditions which can lead to chronic liver disease. So if you have this patient, it is best that you work up for common conditions like fatty liver, Hep C, Hep B. If not, then you have to look at things like hemochromatosis, Wilson's disease, also primary biliary cirrhosis, which is more commonly seen in females, and very rarely primary sclerosing cholangitis, which can also give rise to this chronic liver disease. Again, it is your blood tests, your imaging, and the clinical history which will guide you as to which investigations to follow. And if all your investigations draw a blank, then a liver biopsy in this case is absolutely mandatory. Because many of these female patients are actually having autoimmune hepatitis, where without a liver biopsy, you will not be able to stamp the diagnosis. So if it is autoimmune hepatitis, it gives very gratifying results when you treat it adequately, and these patients are very well controlled and cured with treatment.
Thank you, sir.
Another thing, just I'm sorry, Laksh, to interrupt you.
Yeah.
Another thing, please keep in mind, you have a patient who walks into your OPD absolutely asymptomatic, but has a report, sonography report in a health checkup of fatty liver. Do not ignore it. Always ask for an SGPT, see the PT and the serum proteins for the synthetic dysfunction if it exists, and treat it. Because most of the NASH, as we used to call it, now the terminology has changed to metabolic associated liver disease. Now it is called MAFLD. Instead of NAFLD, it is now known as MAFLD, metabolic associated fatty liver disease. Diabetics, patients with hypothyroidism, obesity, all these patients are sitting ducks for fatty liver. Also keep in mind that you have patients with isolated hypertransaminasemia. Always ask for their viral markers. Obviously, rule out alcohol, because that is something to be ruled out in all cases of liver dysfunction. But also keep in mind that these patients could be having viral hepatitis, and therefore that needs to be addressed. One thing which I didn't mention in my talk is chronic Hep C. I already talked about chronic Hep B. Similarly, for chronic Hep C, if your patient has acute viral hepatitis C and is positive after 6 months, then this is chronic Hep C. Now, chronic Hep C has 6 types of genotypes, genotype 1 to 6. In India, we usually find genotype 1 and 3. And now the good news is that with the present antivirals, which are oral, 98 to 100% success rate is achieved in 6 months of antiviral treatment. So after smallpox, if we play our cards right, we might be able to eradicate Hep C, because we now have such potent drugs. There was a time just 10 years back when the situation was hopeless and all we could give was pegylated interferon. So for chronic Hep C, we now have drugs like velpatasvir, we have sofosbuvir, and there are multiple other drugs also which we keep using, which are absolutely wonderful. So now we have what are known as pan-genomic Hep C drugs, which can be used in all genotypes. So if it is genotype 1, you would need to give the medicine for 6 months. If it is genotype 3, you would need to give the medicine for 3 months. And these are all oral drugs, safe drugs, well tolerated drugs. So it's a complete paradigm shift. Unlike hepatitis B, where the medicine may need to be continued lifelong, here it is over in 6 months. So
Hmm.
that is the most wonderful part about the treatment of chronic hepatitis C at this point. And also keep in mind, every patient of hepatitis C, irrespective of the activity of the virus, needs to be treated because the chances of HCC happening with hepatitis C are nearly
Oh,
70 80%. So it always needs to be treated. I'm sorry, I just volunteered this information without any question, but I think the audience needs to be aware of this.
yes, sir. Thank you so much, sir. Dr. Deepak has asked about obeticholic acid versus saraglitazar in non-alcoholic fatty liver disease.
Obeticholic acid versus saroglitazar. Is that your question?
Yes, in
Okay.
cases of NASH.
In cases of fatty liver disease. Okay, now,
Hmm.
Dr. Deepak, that's a very good question, but that is a seminar of a full day in itself. But let me try to briefly summarize to you. Obeticholic acid came up with a lot of fanfare, and we all thought that we had a good drug. However, the problem with obeticholic acid is that it hasn't lived up to the hype, and we are not seeing the results which were promised by the makers of this drug when they launched it. However, it is a reasonable drug to use because we don't have too many drugs to use for fatty liver right now, which are evidence based. Because our armamentarium consists of UDCA, vitamin E, pentoxifylline, weight loss, bariatric surgery, and treatment of the underlying cause, which could be diabetes or other metabolic conditions. None of this is really foolproof. So, obeticholic acid has been found to have limited utility. The problem with obeticholic acid is if you give it in the exact dose which is recommended, which would be 10 milligrams 3 times a day, there is intractable pruritus. These are patients who are miserable due to the pruritus, and OCA leads to that. Now, saroglitazar is basically a novel drug, and saroglitazar is something which has been launched by an Ahmedabad-based company, and they have the worldwide patent on it. I was part of the clinical trials for saroglitazar. Saroglitazar did give us very good results initially. However, I think that proof of the pudding will be in the eating, and I'm again a little despondent because I'm not seeing that same sort of relief with saroglitazar in patients of fatty liver. We are finding up to 65% reduction in the triglyceride levels, and we have found the best results of saroglitazar in dyslipidemic diabetics. It is not in fatty liver, but dyslipidemic diabetics. Now, suffice to say that if a diabetic patient with dyslipidemia has an improvement in the lipid profile, some element of benefit will also accrue for the fatty liver. However, for the cost and the fact that one has to take it for months together, it may not be an ideal drug. We are now looking at some other drugs which are in the pipeline, which are known as PPAR alpha and gamma agonists, which should be in the market in a few months' time, and hopefully they will be far better in treating fatty liver. For the present, I would say you can use saroglitazar, you can use OCA. Be aware of the fact that they are not going to work as well as we expect them to. But if your patient genuinely requires uh, medication, and this would again depend on their fibroscan score. If it is more than F4, then definitely you could give them these drugs as a bridge till we have better drugs.
Thank you so much, sir. So due to the time constraint, I'll take the last question. Dr. Vinay had asked, during your talk, you had mentioned about milk. So why should milk not be used in cases of jaundice?
Why should, I'm sorry?
Milk. Why milk should not be used in cases of gallstones and jaundice?
See, milk, I said when you have patients with jaundice who are nauseous, who are feeling bloated due to the jaundice, have loss of appetite, one has to avoid anything which is fat rich. Most of the milk which we use has a fair amount of fat in it, and that can lead to problems. Secondly, milk causes a lot of gallbladder contraction. Now, in a patient with already having severe nausea and having dyspeptic signs, giving milk will actually add to the dyspepsia and make the patient more miserable. So that's the whole idea of not giving milk. I'm fine with you giving them ice cream and all, which is fine, far better for them, far more palatable for them, and also gives them large amount of calories with a small amount of portion size. Again, like I said, if your patient can take it, it's fine, but it is better to avoid anything very fried and spicy and very deep fried, something which will lead to more work for the liver and the gallbladder has to be avoided in stages of acute hepatitis.
Thank you so much, sir. Uh, and I think we need to conclude the session. We really, as always, we had a very informative discussion with you, sir. Especially the Q&As of your session are always up to the mark with lot of questions. And we can see more than 700 reactions we have got. Thank you so much, sir, for your insight.
My pleasure, Laksh. My pleasure, absolutely. It's always a pleasure to be on your platform. And I love this interaction, and that keeps us all going. Thank you so much.